Hello, everyone. Welcome to the fourth 2020 IWMF Global Educational Webinar. I'm Shirley Gantz, WM patient diagnosed in 2012, member of the IWMF Board of Trustees, and editor of its Torch magazine. It's exciting to be part of an organization that does so much to support and inform those of us with Waldenstrom's, not to mention the ongoing funding of research to find a cure. So today it's my pleasure to introduce Dr. Edward Libby of the Seattle Cancer Care Alliance and the University of Washington. He's going to help us understand the basics of blood and bone marrow testing for WM. And at the conclusion of Dr. Libby's lecture, we're going to share a live question and answer session. So thank you, and over to you, Dr. Libby.
Hello, I'm very pleased to be here as a guest of the International Waldenstrom's Foundation. It's a great honor to speak with you and to have the opportunity to share my thoughts about Waldenstrom's macroglobulinemia. Let me share my screen. So today we're going to talk about understanding your blood and bone marrow test results, and I'm hoping that I can shed some light on that issue for those of you WMers in the audience. I'm an associate professor of medicine in the Division of Medical Oncology at the University of Washington, and I'm also the director of the Multiple Myeloma Service. Within the Multiple Myeloma Service, it also includes patients with Waldenstrom's macroglobulinemia and amyloidosis. So let's be honest. What comes out of your physician's mouth in the office is often confusing gibberish. And when he or she leaves the office, many patients, myself included, when I see a physician for some of if I have a personal medical issue, may leave us confused and not knowing really what was said, a little bit scared because a lot was said, but much of it went over our heads. This is a problem that's well known in medicine, that physicians may speak over patients' heads and really don't communicate the information that they really want to get to patients. I want to first of all, by talking about that problem, bring your attention to this pamphlet that is available on the IWMF website on medical testing. It is a really valuable research source for you, and you can either download it and print it at home, or you could ask for a printed copy through the IWMF website. So I highly recommend this. So in spite of the fact that physicians often don't communicate well to patients, even though they're trying really hard. They use words that are not within our vocabulary. It's important for you to know what's going on. And if you have a family member or a friend, or if you yourself can get at least a rough idea of what's going on with blood tests, you're going to have a lot of power to fight your disease, a lot more comfort, you'll sleep better, less anxiety because you'll know what's going on. You'll have a better idea of what's really happening to you. And I think having more confidence in the future is a wonderful thing. And I don't want my patients or any patients to be simply waiting, feeling as though they're just waiting helplessly for the other shoe to drop. So first of all, let's talk about bone marrow testing. Why do we need it? How do we do it? And what does it mean? Well, Waldenstrom's is a disease of several different types of cells. They're all very closely related, but they're not exactly the same. And when you look in the bone marrow of Waldenstrom's patients, you'll see several different cells in oversupply, too many of them. So small B-cell lymphocytes, plasmacytoid lymphocytes, which is an interesting word because it means cells that look like two different types of cells. They look like both like plasma cells, but also like lymphocytes, and cells that simply look like plasma cells. So I think of it as a hybrid disease with several different but very similar and closely related cell types that together cause this disease and cause its symptoms. And in 2020, 2021, a bone marrow biopsy is mandatory to diagnose Waldenstrom's macroglobulinemia. It should not be diagnosed without a bone marrow biopsy. So why a bone marrow biopsy? Well, that's where the disease is. In most patients, it's primarily in their bone marrow. It is sometimes in the lymph nodes, sometimes in the spleen. We virtually never biopsy the spleen. We can biopsy lymph nodes, but the great majority of the time it's in the bone marrow, and a bone marrow biopsy is a relatively uncomplicated, safe procedure that we can use to diagnose the disease with a lot of confidence. I've had a bone marrow biopsy, so I do know what they feel like. Yes, it can be uncomfortable, and I know sometimes they're downright painful if for a number of different reasons. But generally, they're well tolerated, and they give us a tremendous amount of information about this disease. And a clear diagnosis is so important because it helps to avoid what I'll call therapeutic misadventures. What is a therapeutic misadventure? This is actually a term that is used in medicine. That's when your physician treats you for one disease, but you actually have another disease. You don't want that. We don't want that. So we need to go out of our way to be sure we know what we're treating. And a bone marrow biopsy will go a long way to allowing that to happen. So how do we do it? Most of the people in the audience are very familiar with this. So with a bone marrow biopsy, generally most people who perform bone marrow biopsies will have the patient lying on their chest and with arms out, as in this picture. We put the area of the buttocks to sleep. You can see that there. This area is put to sleep about a $1/2 size with lidocaine, the same medicine that a dentist uses to put your mouth to sleep. And you should really only feel dullness there if we're pushing. And if we push a needle through there, it's only going to feel dull. So you can see in this little inset here how the needle goes through. So it has a large handle, and the physician or the operator can twist the needle, can get into the bone, and can get a little fragment of bone with this needle. And also, when the needle is in the bone, we can withdraw some liquid bone marrow. And that marrow will give us a huge amount of information about how your bone marrow is working and are there any abnormal cells there. Here's another picture showing the portion of the bone marrow biopsy and aspirate where we're removing the aspiration. We're doing the aspiration. We're aspirating liquid bone marrow from within the bone. So you can see the needles in there. Then there's a little bit of blood that's actually liquid bone marrow that's in the top of the syringe. That is then, as I'm going to show you in just a second, is then put onto a glass slide. Some stain is put on it, and we can look at it through a microscope and make the diagnosis or increase our suspicion for the diagnosis. I have taken some liberties with this slide, and those pictures are not exactly Waldenstrom cells, but I think the point is still made really well here, that on the bottom it shows a normal bone marrow and there's a mixture of different types of cells, and on the top there's a monotonous group of cells. They all look roughly the same. That's more of a cancer type of a picture where the mixture, the family of many different types of cells in a normal bone marrow is kind of obliterated or obscured by just a large population of the same kind of cell over and over, and that's usually the cancer cell. So this is what a bone marrow technician does with that liquid bone marrow that's removed. They use an eyedropper kind of thing. The liquid bone marrow is squirted into a petri dish, as you can see. Then they pull it out with an eyedropper and put it on glass slides, as they're showing right here. And they put it very thinly on the glass slides, and then it can be stained, and it can be looked at through a microscope. So your pathologist can then look at these glass slides. There needs to be a very small amount of the material on the glass slide, or you won't be able to see through it and look at the cells. So very thinly smeared, stained, looked at through the microscope. Now, I just want to point out how important the pathologist is in the diagnosis of Waldenstrom's macroglobulinemia. I think of the pathologist, and for all cancers really, I think of the pathologist as being my partner. He or she is really silently in the office when I'm seeing the patient, and I'm relying on them to really help me to cinch this diagnosis. In the old days, the days are long gone when your hematologist oncologist would do the bone marrow themselves. We still do our own bone marrows, but often, and then stain it and then look at it through the microscope themselves and make the diagnosis themselves. In this day and age, we need specialists and sub-subspecialists and sub-sub-subspecialists, and all of us have very unique pieces of the job of taking care of a patient. And the pathologist is so important, and there are partners in the clinic, even though you won't meet them. Rarely would you ever meet one. So here's a bone marrow from a patient with Waldenstrom's macroglobulinemia, and I put this up to just so you could have some idea of what the slides really look like, and they do look somewhat like the slides that I showed you before. And on the left, you can see the lymphocytes. These are cells where the blue nucleolus pretty much fills up the cell completely, and there's a nice clump of them there on the left side of this slide. And up on the right, I've got the arrow pointing just past that arrow. There's a cell that looks kind of like a fried egg, a purple fried egg is what I like to describe them as. There's some lighter bluish, what's called cytoplasm, and then there's the center circle that's the nucleus, and that's more of a plasma cell looking thing. And as I said, Waldenstrom's patients have a mixture of cells, lymphocytes, plasma cells, and cells that are a combination of both, lymphoplasmacytoid cells. Now, this is the bone marrow of a patient I recently diagnosed with Waldenstrom's macroglobulinemia, and this is the actual report. And the pathologist looked through the microscope and then counted the number of normal cells and the number of abnormal cells in the bone marrow. And what their diagnosis was, there was a low-grade small B-cell lymphoma. I mentioned those cells before, but these B cells had some features of plasma cells. That's strange. They looked like two different types of cells, classic for Waldenstrom's, or LPL, lymphoplasmacytic lymphoma. And then they counted it and mentioned that 40% of the cells in the bone marrow were these abnormal cells. So 2 out of 5 cells is an abnormal cell. Normally that should be 0. So the bone marrow is slowly filling up with these abnormal cells. This isn't a really large number of cells, but it could easily make you very sick. You might have no symptoms, you might have symptoms. This particular patient had a very high IgM in the multiple thousands, in the 8 to 9,000s, and was feeling very weak because they were anemic. So finally, then in conclusion, the pathologist said these features are compatible with lymphoplasmacytic lymphoma. Whenever you see that word, lymphoplasmacytic lymphoma, it's often abbreviated as LPL, and that's a code word for WM, for Waldenstrom's. And the pathologist pointed out that it could be other things. It could be marginal zone lymphoma, which can look like lymphoplasmacytic lymphoma or WM. That's usually the number one thing that we think about when we're looking at a bone marrow like this, is maybe it's not WM, maybe it's something else. But if the IgM is significantly elevated, the great majority of the time it's going to be Waldenstrom's. And there's some other tests now that really help us to finalize the diagnosis with confidence. And one of them, the most important one, is the MYD88 testing, which most of you are familiar with. So MYD88 is a gene that's found in Waldenstrom's cells. And if it's mutated, it's found in Waldenstrom cells. So we can see this gene in 2 forms in a patient with WM.
Unknown caller.
And the most common in WM, what we generally see is that it's mutated. The MYD88 is mutated, and that's in at least 90 to 95% of patients with WM. So this genetic test has become almost specific, or a slam dunk. If you see the Waldenstrom's type cells in the marrow, you get this gene testing, and the mutation is positive, then that's almost certainly WM. If it's negative, and it may not be, it may be something else. It might be that marginal zone lymphoma I was talking about before. So again, in this day and age, all patients, when they have a bone marrow and there's a suspicion for Waldenstrom's, should have the MYD88 test, and you can expect that it's almost always going to be positive if you have WM. CXCR4 testing is also very important. It's not mandatory if you suspect Waldenstrom's. I am routinely getting it in all of my patients when I'm attempting to make the diagnosis of Waldenstrom's. And the CXCR4 mutation is a mutation that will predict for us how well you're going to respond to the drug ibrutinib. It does not, both MYD88 and CXCR4 really don't have a bearing on how you're going to respond to traditional chemotherapy like bendamustine or rituximab, but they're very important as regards ibrutinib or Imbruvica. So I do routinely get the MYD88 and the CXCR4 in order to be able to predict how well somebody is going to respond to the ibrutinib. With CXCR4, you want to be wild type. You do not want to have the what's called the WIM mutation or WHIM mutation in CXCR4. If you have the WHIM mutation in the CXCR4 gene, then you will be resistant, essentially somewhat resistant to ibrutinib. You will respond much more slowly and you will respond less robustly. It does not mean that you will not respond, but you will have a lower likelihood of responding and responding rapidly. So the CXCR4 WIM, WHIM mutation is you prefer not to have that. For most patients, I think it has not been checked. If you're doing well, by the way, and you haven't had an MYD88 test, I don't think it's necessary to go back and have a bone marrow to see if you're MYD88 positive. But certainly if you have a bone marrow in the future, I would get that test. These genetic tests, when oncologists talk about genetic testing in their patients, I'm talking about the genes in your cancer cells, in your Waldenstrom cells, not in most of your body. The vast majority of cells in your body are normal. Your non-Waldenstrom cells do not have the MYD88 or the CXCR4 genes. You don't have to worry about that. These are just the cancer cells we're testing. So we also get a lot of blood tests, as you know, in patients with WM. And why do we do that? Well, to follow the results of treatment, to see if your IgM is improving, to see if you're having any complications. Are you having liver problems, kidney problems, etc., and to see if the disease is returning. And so I'm going to talk in depth about some of the most basic testing that you have with WM to hopefully to help you feel more prepared the next time you see your oncologist or hematologist. So the blood count's very important in Waldenstrom's. Anemia is one of the most common signs of patients with Waldenstrom's. So remember that the complete blood count, which is done all the time, is cheap, it's easy to get. In your blood, there are three major types of cells. The one we all know about is red blood cells. They all look the same, they all have the same job, they carry oxygen. And if they're too low, your red blood cells, you're anemic. Then there's another cell we hardly talk about, and that's the platelets. They help your blood to clot. They all look roughly the same, they only have one job. They help blood to clot. And then the third type of blood cell, major type of blood cell in your bloodstream, are called the white blood cells. And they're a little bit unique because it's not just one type of cell. It's many different types of cells, maybe 1 to 2 dozen, depending on how you count them. But it's a number of different cells that I describe as being in the white blood cell family. And together, these different cells, all of which are called white blood cells, fight infections. That's their main job. And each of them has a different job in fighting infections, and we're going to talk a little bit about that. So white blood cells, red blood cells, and platelets. And we're going to talk in particular about white blood cells. So this is what, if we took your blood, and remember I had showed you earlier what a bone marrow smear might look like how you might prepare one on a glass slide. The same thing is done with blood. If you smear blood on a glass slide and look through that blood on the slide, you'll see a picture somewhat like this. You can see in the upper left hand here is the erythrocyte. That's another word for red blood cells. So erythrocytes are red blood cells. Neutrophils, there's one almost right in the middle there. There he is, or she. And with sort of the octopus thing in the middle and the little dots. Neutrophils fight infections. There are key infection-fighting cells. They've got a basophil and an eosinophil. Those are both white blood cells. And the lymphocyte is also a key infection-fighting cell. And remember, we've already been talking about lymphocytes because lymphocytes are abnormal lymphocytes or cancerous lymphocytes are part of Waldenstrom's, the small B cell cancer. And then there's some platelets there. So this is a real smear, and wow, it looks just about the same. Again, there's a band neutrophil. That's a very young neutrophil, but that's an infection-fighting cell up there in the upper left. A platelet is a little tiny, almost a fragment of a cell there. Erythrocytes, those are the red blood cells. They're thinner in the middle. It sort of looks like they have a mouth, and that's the way they all look on the smear. Then there's a lymphocyte, a neutrophil, basophils, all white blood cells. Eosinophils and basophils tend to be involved in allergic reactions, but neutrophils and lymphocytes and monocytes, very important for infections. So as I said, the white blood cells are a family of cells that fight infections. And we check those every time you get a complete blood count, which is probably every time you see your hematologist oncologist. They're checking these counts. It's very easy to do and cheap. So let's look at a real blood count done on a patient. First of all, there's the white blood cells at the very top, probably because they're so important to us when we're seeing patients. And these patients are normal. We've got the normal range over on the right side of the slide. Normal would be 4.3 to 10, and they're 4.75. So this patient's white blood cells are normal. And then is the hemoglobin and the hematocrit. Now the RBCs are also low, and they do tend to, the red blood cell count, that's what that stands for, tends to follow the hemoglobin and the hematocrit. But I think as a patient, I recommend you focus on either the hemoglobin or the hematocrit. One or the other, just pick one and know what's normal, roughly, and know what your hemoglobin or your hematocrit is. So this is the patient I mentioned earlier, and their hemoglobin is 8.1, which is significantly down, maybe 40% from normal. And the hematocrit is also low. It's 26%, whereas the normal range is at the low normal is 38%. So this patient is significantly anemic, and in fact, he was significantly symptomatic. He felt exhausted and was unable to do much activity without running out of breath. So pick one or the other and get to know what your hemoglobin or your hematocrit usually is. If they're going down, then you're becoming anemic, and that's a sign, that's a potential signal that your Waldenstrom's is returning. Now, there are other things that can cause anemia, but in a patient with Waldenstrom's, if they're becoming more and more anemic, you worry that the disease is returning. So I think the two most important things in the CBC for a WM patient is either the hemoglobin or the hematocrit. I showed you there are the platelets there, the PLTs, and they tend to be normal in WM, not always, but they tend to be. So now there's another test that we get, and also let me go back here. Hopefully it'll let me do it. Yes, okay. So notice this is 18 or 20 different tests. There's a lot of numbers on there. That's scary if you're a patient. It's like, gee, what does all this stuff mean? Don't worry about it. A lot of this, the computer generates a lot of numbers. The machine that does this test generates a lot of numbers that really, in routine practice, they don't help me. They don't help your oncologist much at all. So I focus on what really matters, again, hemoglobin and hematocrit. But there's a lot of tests there to look at and to worry about. I encourage you not to. You can ask your doctor, though, if you need to be worried. So then there's the other test that's routinely obtained is the basic metabolic profile. It has several names, the BMP, basic metabolic profile, or the metabolic profile, but usually one of those three names is used. And lots of general information is taken from this test. But again, a lot of it really isn't relevant to someone with Waldenstrom's. For instance, kidney function. It's nice to know that your kidney function is normal. If we're giving you chemotherapy, we want to know that. But much of the time, Waldenstrom's, the kidneys tend to not to be the biggest problem with Waldenstrom's. So yes, I like to know that we want to know that your kidney function is normal. But no, it's not the important information that we get, in the most important information we're getting with every visit. Also, the metabolic profile gives us measurement of your minerals, your potassium, your sodium, your chloride, your CO2. It's not that important, really, for WM. I'm trying to give you the very basic tests. Liver function testing, it's nice to know, but again, it doesn't usually directly relate to WM. So here's a basic metabolic panel. Again, another 18 or 20 tests. So with those two tests, you've got 40 different numbers roughly to look at. You know some of them are going to be abnormal. It's virtually guaranteed. So, but usually it's not going to relate to your disease. So yes, this person's total bilirubin is slightly elevated at 1.8. It's probably not important. I'm not going to discuss why, because we do see this routinely in patients. But these are a lot of numbers that don't directly relate to a WM patient. There's the creatinine again, the kidney function. Now, you go back and talk about the bone marrow. On the left, I have a femur, which is the biggest bone in your leg, the upper bone, and it's been sawed in half, and to give you a look into the bone and to give you an example to try to give you some insight into bone marrow. And inside of the bones, especially the large bones like your spinal bones, your arm bones, your leg bones, your pelvis, your ribs, that's where the bone marrow is, and that's where blood cells are made. And we've said already that one of the blood cells is lymphocytes. You saw a picture of those on the blood smear. But another member of the another important member of the white blood cell family are plasma cells. And so this picture shows some plasma cells, and they're also an important member of the white blood cell family. I usually describe them as inky doll's eyes. They look a little bit like doll's eyes. And what those cells do, they live in the bone marrow. Plasma cells generally do not go into the bloodstream. Unlike lymphocytes, we saw some lymphocytes in the bloodstream earlier. Plasma cells, which are another member of the white blood cell family, generally aren't in the bloodstream. They stay in the bone marrow, and that's where they do their job. And their primary job, one of their biggest jobs, is to make proteins or immunoglobulins that we call antibodies. And I think most of you are familiar with this concept of the antibodies or the immunoglobulins. Immunoglobulins fight infections, and we take advantage of that. When you got your flu shot this year, it fooled the plasma cells into thinking you had the flu, and they started pouring out antibodies that go into the bloodstream and fight the flu virus when it shows up a couple of months later. So we take advantage of plasma cells with vaccinations. The same thing with the Pneumovax, the pneumonia vaccine. We give a dead virus or a modified virus to a patient. The plasma cells and the lymphocytes make antibodies to try to kill the virus or the bacterium. And then when you do inhale a virus or a bacterium months later or even years later, in the case of pneumonia, you're much better prepared to fight the infection, and you either get a milder form of it or you don't get the infection at all. That's the normal situation. But in Waldenstrom's, you now have abnormal cells. And remember, I've said that it's a family of cells. This is a weird hybrid disease. So you have abnormal or cancerous lymphocytes, plasma cells, and lymphoplasmacytic cells. They're all related. It's all the same cancer, but they're not exactly the same. So you have cancerous lymphocytes, plasma cells, and lymphoplasmacytic cells. And the artist here has shown there are many more of them in the bone marrow. They look weird, they're not normal, and they make a bunch more antibodies. And those antibodies are immunoglobulins. Guess what kind they are? They're IgM. That's what is distinctive for Waldenstrom's, that increased production of antibodies in Waldenstrom's macroglobulinemia is always IgM. So that helps us to identify the disease. And we can measure the IgM very easily in your bloodstream. So this is another overall 30,000-foot view of the disease. The cells increase in your bone marrow. They occupy the bone marrow and tend to push out the normal cells, and they make a lot of one particular kind of antibody, the IgM. What are immunoglobulins? Well, they're one of the major immune-fighting molecules found everywhere in the body. I really like this slide, so I added it to my slide deck. Most people refer to them as antibodies, and there are 5 distinct types of immunoglobulins. They're all shown there, but IgM is the one that we care about as folks who fight WM. Just a picture to give you some rough idea of the way these antibodies look on a molecular level, and you'll notice here that the IgM is the biggest antibody, and that relates to how it can cause hyperviscosity. So we've said hemoglobin and hematocrit or hemoglobin, one or the other. You want to know those. And what else do you want to know? Well, you want to know your IgM level. And there are some other tests that relate to your IgM level, but the IgM level is what most physicians, the vast majority of hematologists, oncologists will get to follow your WM and see how it's doing from visit to visit. So you really want to have a handle on your IgM level. The M spike is important. It has some other names like electrophoresis or SPEP, but I think that's in general is going to confuse the patient, and that the real bottom line, most important number that we follow is your IgM level, your IgM immunoglobulin level. Forget the M spike, forget the SPEP. What's my IgM, doc? Is it going up? That's not good. Is it stable? That's probably okay. If it's going down, that's even better. Serum viscosity, I think, is ordered all too often in routine practice. Many IgMers, even if they feel fine and their disease isn't doing anything, their IgM will be elevated a little bit. And if your IgM gets up to 2,000 to 3,000, your serum viscosity will be elevated. But it does not mean you have to be treated. So the serum viscosity essentially never tells us if somebody needs to be treated. It's how you feel that tells us whether or not you need to be treated. But it is true, the higher the IgM level, the higher your viscosity will be and the thicker your blood will be. But no matter how high the IgM is, for all practical purposes, the IgM level should never be used to make the decision as whether or not to treat a patient. It's how the patient feels. So even if you have hyperviscosity, meaning your viscosity is above normal, you may have no symptoms and therefore don't need to be treated. We should not treat the number, we should treat the patient. No symptoms or signs, no treatment. And I think many physicians routinely order the serum viscosity, but I don't know, personally, I don't see the value in it because it doesn't help us to decide what to do. It's that IgM and how you feel and your hemoglobin or your hematocrit that really tells us what to do. Other symptoms too, it's not quite that simple, but I'm trying to simplify it for you, the patient. So here is a report showing both the M spike that I mentioned earlier, which is sometimes called the SPEP, which is also sometimes called the electrophoresis. And what I want to say is I don't think that number is that important for you as a patient. And probably the biggest reason is that many physicians don't order it. It gives us the same kind of information that the total immunoglobulin level, which is below, gives us. But I think most of the time your physician is just going to be ordering the total IgM level, and that's just fine. That's just fine. It's nice to have the M spike, but really just the total IgM is enough. So this is the same patient here, and you can see that his M spike indeed is 1.8. It's not normal. It should be 0. So the M spike, just for those of you who are interested, in the SPAP or the M spike, we can use a laboratory instrument to separate normal from abnormal IgM. We can completely separate out. The IgM that your WM cells makes is abnormal. That's an important point. The IgM that your WM cells make is abnormal. You will also, those of you with WM in the audience, you have both abnormal IgM in your body and normal IgM. The SPEP will separate it out. So this number, this 1.8 for an M spike, that's just the abnormal IgM. Below that is the total IgM, the serum IgM. And the numbers are different, the units, and that's okay. But the total IgM is 2,849. And the total IgM, you can imagine, with the word total being part of it, total IgM is the combination of normal and abnormal. And it's okay that it's not just the abnormal. You still get the rough idea. If the total IgM is going up, most of that's probably abnormal IgM. So really just pay attention to your IgM. That's really the number that matters. The SPEP is probably just going to confuse you. So now we've come up with, let's see, we said hemoglobin or hematocrit. We said total IgM. Those are some of the most important numbers to pay attention to. And there's the M spike. I've already said this, so I'm not going to cover it. This is a picture of what a serum protein electrophoresis looks like, and I'm just putting it up for fun because I don't think you need to focus on this. I want you to focus on the total IgM. But this is what it looks like, what we get from the laboratory. And in the laboratory, let's see if I can get a pointer going. Okay, that big spike there, that big hump, is normal protein in the blood, or albumin. So a large percentage, all these little humps here that you see going along, those are the different proteins that are present in the bloodstream. And there are many, many different proteins present in the bloodstream. In this one, the hump, which it says is 65% of what's seen in the bloodstream there, you can see they're saying is albumin. That's a normal protein. And then there's all these other proteins with these little humps there, and they represent different enzymes and things that are in the patient's body. So that's a normal electrophoresis. But let's look at an abnormal electrophoresis. So there now suddenly appears, here's still albumin in this patient, but down the road here is a new spike, and that's abnormal protein. That's all abnormal, and that's the true M spike. This is done using electricity. You can separate out the different proteins, and that's why they call it a spike, because it spikes up. So just this is an FYI. I don't want you to worry about it. You're going to focus on the total IgM. So yes, it's all very confusing, but I hope I'm giving you some clarity here. I feel a little bit like this myself. So my advice, focus on the total IgM. This is what most oncologists use to follow the disease. Some do get an SPEP or an M spike, some do not. I think most don't. Your IgM, this is important. Your IgM, your total IgM, will never be zero. Never be zero, because we all have normal IgM in our bodies. So if you can just, usually, let's say you started off, whatever the IgM level is, somebody who's anemic and their IgM is moderately elevated, 3,000 or 4,000. Our goal is usually just to get it down by, if we're lucky, maybe 50%. We're not going to get it to zero. The goal of treatment in Waldenstrom's is for the patient to feel better, not to get the IgM into the normal range. And in fact, it's very difficult to get the IgM to return to the normal range. It's a minority of patients where their IgM will become normal. I do have patients like that, but in most patients, it's just going to come down maybe half by half. Many patients are anemic, so the IgM comes down and their blood count goes up, and they feel better, and that can last for years. That's the goal. Normalizing your blood, your IgM is not the goal. It's never the goal. Because it's so hard to do, and there's no evidence that patients will feel better if their IgM is normal. So be aware of that. Now, what about viscosity? We mentioned that a little bit. In general, as I said, I don't think routine measurement of viscosities is valuable. It may be elevated, but it doesn't matter if you feel fine. Patients do not have symptoms until their viscosity is at least 3 to 4 centipoise or CP. You see there on the bottom right is a couple of examples of viscosity. I don't know if that's honey or syrup there going into the spoon, and that's sort of, it looks like sparkling water going into a glass. Water, by definition, has a viscosity of 1. My guess is that the viscosity of honey or syrup is at least 10 or 20, maybe more like 30 or 40. I do see patients fairly often where their viscosity is 5 to 10 with Waldenstrom's. I don't treat them unless they're symptomatic. So, but this viscosity measurement gives us some idea of how much IgM is in your blood. But we already know that by checking your IgM. And many patients may have high viscosities, even viscosities of 7, 8, 9, and no symptoms at all. And they don't have to be treated. That's important. But some symptoms that you should look for as a patient, as a WM patient, no doubt about it, be aware of these symptoms. Headaches, unusual headaches, recurrent nosebleeds, very common with hyperviscosity, changes in your vision, dizziness, a spinning sensation, that we call it vertigo in medicine, and deafness. Those can be symptoms of mild hyperviscosity. Severe hyperviscosity, you may have confusion, even dementia, stroke, or coma. Less commonly, patients can have cardiac symptoms like heart failure. The treatment is very straightforward. We do something called plasma exchange. It can be done very rapidly and easily if you're near a large medical center. If you don't have a large medical center near you, it can be hard to get plasma exchange. But we take your blood out of your body, we remove the abnormal immunoglobulins, and then we replace them with normal immunoglobulins. And it's called plasma exchange. And it's done a significant number of patients, maybe 20 to 30%, maybe a little bit higher. Patients with WM will at some point in their time with the disease require plasma exchange. And it's easy, relatively easy to do, but you need a large, busy center near you to get it in a hurry. So I want to thank you so much for the opportunity to speak. I want to thank the IWMF for this chance. I really get a lot of gratification taking care of patients with this rare, unique, and unusual disease, and have a wonderful day.
Well, let's get started with the Q&A with Dr. Ed Libby. Our first question is, okay, how has your management of WM changed during the COVID era? If so, what are your recommendations?
Excellent question. I think part of this is a discussion with the patient regarding the risks and benefits of therapy. There are some drugs that affect the immune system more than others. And so patients may not wish to do anything that will increase their risk for having complications of COVID if they contract it. And so monoclonal antibodies, for instance, they do affect the immune system, and things like rituximab or ofatumumab could impair the immune system and make you more sensitive to viral attacks or viral infections. And so I do that in conjunction with the patient and using their personal feelings about getting treated or not. Now, there are patients who really require therapy, and they're so ill that the discussion of the risk of COVID is to some degree not is moot, because you've got to treat them or they're going to become end up in the hospital if you don't. So or they're already in the hospital. So I think overall my discussion of treatment has not changed a lot. I'm very conservative in patients that I choose to treat and those that I don't, which is true for most WM treaters. But I have concerns about giving both chemotherapy like bendamustine or biological therapy like rituximab, because they can affect the immune system. They do affect the immune system.
Okay. When do you think we'll have a peripheral blood alternative to a bone marrow biopsy? I think we're all really interested in that.
Yeah, that's a great question. A long time from now, I think. Well, that which could be a long time, could be 5 to 10 years. In terms of gauging how much lymphoma or Waldenstrom's that a patient has in their bone marrow, that could be a very long time. But detecting the disease in the bloodstream might be within 5 to 10 years. Generally, these cells are not seen in the bloodstream. So I think bone marrows are going to be with us for the foreseeable future. That's my expectation. That is a very exciting technology, though, looking at either cells in the bloodstream or DNA or RNA in the bloodstream that comes from cells that are in the bone marrow.
Well, we look forward to that. Are bone marrow biopsies necessary after treatment, or are they just needed for the initial diagnosis?
Great question. Generally, they're usually not needed on a routine basis for your non-study patient after treatment. And most research studies will not ask patients to have bone marrow biopsies as they're going through their therapies. So I don't get bone marrow biopsies very often in my patients, and I suspect most WM treaters also do not routinely get bone marrow biopsies to determine response. You can usually do that by looking at the Igm level, at the hemoglobin and hematocrit. So in my opinion, getting a bone marrow biopsy should not be a routine part of assessing the patient's clinical status in follow-up for treatment.
So is it critical to know whether you have the MYD88 or the CXCR4 genetic mutations before starting ibrutinib, since the science shows that individuals with CXCR4 don't respond as well to ibrutinib?
I think it is, especially the MYD88, but a clinician, a hematologist oncologist, could easily find themselves in a situation where patients not responding well to ibrutinib, but you don't have that testing to begin with, and it would make it difficult to decide, do I continue the ibrutinib, knowing that in many people, even who are CXCR4 positive, they will respond months later, much more slowly. So you could have hope then that they're going to respond eventually, and if they're doing okay, you could continue the drug. But if you simply don't know if the patient has that mutation or not, you really don't know the source of the resistance, and you don't know whether or not to consider continuing the drug. In terms of MYD88, it's very important now because it's really central to our diagnosis. It doesn't absolutely make the diagnosis. If you're MYD88 positive, that does not mean you unequivocally have Waldenstrom's, because other diseases have that mutation as well. But it's very key to making the diagnosis, and of course, it's critical in terms of whether or not you're going to respond to ibrutinib. So if you're starting ibrutinib, if you're about to start ibrutinib or a different Bruton's tyrosine kinase inhibitor, you should have that mutation should be determined, in my opinion.
Well, someone has asked, when I was first diagnosed, I had a bone marrow biopsy done, which found I was MYD88 mutated, but negative for the CXCR4 mutation. Is it important to have bone marrow biopsies periodically in case there is a change from a previous negative mutated status?
Excellent question. I don't think there's a lot of data showing that patients develop mutations to CXCR4. So I don't think that's necessary, but it's a great question. I think it's highly unusual for that to occur. I have not seen reports of that occurring, not to say that it has never happened. So it's not recommended in general.
Why do values such as hemoglobin, hematocrit, WBC, white blood cells, red blood cells, and IgM fluctuate up and down from 1 month to the next, or even within 2 weeks?
Yes, I think a lot of it is probably hydration. So if you've had several glasses of water, or a couple of glasses of water, or some beverage before you get the blood test done, it could change significantly. It also could change, I think, depending on how much stress you're under, and which stress levels change from minute to minute. If you'd had any kind of mild illness in the time between one test and another, I think the short answer is a lot of this is probably due to hydration.
Oh, good to know. Can the detection of MYD88 mutation be affected by the quality or quantity of the tissue collected from the bone marrow aspiration or bone biopsy?
Another great question. It definitely can, and it's not uncommon for me to see patients in whom the sampling from the bone marrow did not get enough cells to do an MYD88 test. So the person in the laboratory who's attempting to detect this mutation has to have a certain number of cells to do that. And bone marrow biopsies are not always successful. Even when they're done in good hands, you may not get into the actual marrow, and you may primarily withdraw blood instead of bone marrow. And we've already said that the blood has very little, if any, Waldenstrom cells in it. So when that occurs, and it's not that uncommon, the MYD88 test will fail, and we won't have a result, and you may have to have another bone marrow biopsy. That is not uncommon, unfortunately.
So if you have WM, is it possible to have your bone marrow look negative?
Well, I think there are a very small number of patients who are felt to have Waldenstrom's macroglobulinemia who are MYD88 negative. This is a very small group of patients. I know that Dr. Treon feels that virtually everyone is positive. That's some of the reason that we haven't seen a closer to 100% in reports presence of MYD88 is limitations of the laboratory that's doing it. So it should be very, very high. But certainly a patient could have a bone marrow biopsy that was inadequate, as I mentioned earlier. Everything else in their story and their blood testing adds up to Waldenstrom's, but they're MYD88 negative. And so I would be suspicious that usually the pathologist will tell the oncologist, we didn't get a good specimen, and so I really can't vouch for whether or not I can't tell you whether or not this patient is MYD88 positive or negative, and you need to consider repeating the study.
So when you take your first look at a bone marrow biopsy result of your patient, what are the first items you scan for as the most important markers?
Well, some of the key things, one of the most important things would be a CD20. So CD20 is a marker on the outside of the bone marrow cell, of the Waldenstrom cell, that tells you whether or not a patient is sensitive to rituximab. And virtually all Waldenstrom's patients are sensitive to rituximab or drugs like rituximab, which would be ofatumumab. Those are anti-CD20 drugs. So CD20 is present on all patients with Waldenstrom's who are untreated, essentially all. And so that is going to be very widely looked for and expected. There are a number of other antigens on the outside of these cells that a laboratory device called a flow cytometer can stain the outside of the cell and look for a number of different markers called CD5, CD13, CD7. There's a number of different markers on the outside of these cells that a flow cytometer can look for, and you can use the different markers on the outside of the cell to identify the cell. Is this cell a Democrat, or is this cell a Republican, or an independent? Since it's many of us will be voting soon or have voted, so I'll use that as an example. The flow cytometer can look at something called the CD markers, and that stands for cluster of differentiation markers on the outside of the Waldenstrom cell, and can identify whether or not it's a Waldenstrom cell or not, or a plasma cell or a lymphocyte.
So what are the ramifications of having a lymphocytic versus a plasmacytic version of Waldenstrom's?
We really don't think of the disease in that way right now. I think that may eventually be understood. In general, patients who have more plasma cells don't have a different course of the disease or a different prognosis than patients who have more lymphocytes. So it's an interesting question, and it's an interesting part of the Waldenstrom's puzzle, but patients their disease doesn't behave dramatically differently. So that is an excellent question. Plasma cell disease, the classic plasma cell disease is multiple myeloma, and patients with multiple myeloma, their bone marrow is full of too many plasma cells, and they're cancerous plasma cells. And their disease is very different from Waldenstrom. So in Waldenstrom's patients who have a lot of plasma cells, they're more plasmacytic. They don't have a multiple myeloma type presentation. So you might think that could happen, but it is not seen. So that is an excellent question. But right now we do not think of the disease in a different manner depending on whether it's more lymphocytic or plasmacytic.
Let's see. Please explain the tests used to evaluate iron status and diagnose iron deficiency anemia. Which blood tests are used to distinguish or follow up WM?
Yes, this is an important question in Waldenstrom's because a significant number of Waldenstrom's patients have iron deficiency anemia, and it's thought to be related to a couple of things. One is a problem with hepcidin, and hepcidin is a protein that helps the body to absorb iron through the intestines. And if you have a problem with hepcidin, that's HEPCIDIN, if you have a hepcidin issue, you may not be bringing iron through the intestines into the body to make red blood cells very well. And that's not something, we can't give you a hepcidin infusion right now to fix that. There's no easy way to fix the hepcidin. But because of that, many patients are low on iron. In addition, it's thought that because of even mild hyperviscosity, Waldenstrom's patients may be losing some iron through the blood vessels of the intestines, very low levels, but chronically that adds up to iron deficiency. So Waldenstrom's patients should have their iron checked at the time of diagnosis, and so many of them are anemic. And if they're iron deficient, it should be replaced. And the iron deficiency could be related to their disease. Now, the last little trick about that is that because they have this hepcidin issue and they don't absorb iron very well through the intestine, it should generally be replaced intravenously. If you're iron deficient and you have Waldenstrom's, you're going to tend to not respond well to iron pills, and therefore it's recommended that the iron be replaced intravenously so you have a successful response. My preferred test for iron deficiency, the older testing was to get a serum iron, or to get the level of iron in the bloodstream, to get something called the total iron binding capacity and the iron saturation. Those still have value, but in general, the best test is the ferritin. And the ferritin can be abnormally high if you have inflammation, but in general, the most straightforward test to obtain to look for iron levels is called the ferritin. And if it's low, then particularly if it gets really low, then the odds are very high that you're iron deficient. One other test that you can do to look for iron deficiency is to stain the bone marrow for iron, because iron is stored in the bone marrow. If you don't see iron there, then that's another strong suggestion that a patient is iron deficient. But I hang my hat on the ferritin level when I want to look for iron deficiency in WM patients. I should mention one other thing, and that is when you're looking at your CBC, your complete blood count, there is a number on there, and I had mentioned there's many numbers on there, many values, but there's something called the MCV, and the MCV is the mean cell volume. How big or small is the red blood cell? And when red blood cells become deficient in iron, they become smaller. And so the MCV gets low in iron deficiency, and that's an excellent clue to iron deficiency. In someone who's anemic and their MCV is below normal, then that's a very strong clue that you're iron deficient.
Oh, interesting. I'd never heard that part before. So how does a cold, flu, or minor infection affect blood counts? Could using an antibiotic affect blood counts? Does that affect diagnosis or follow-up of WM?
I don't know. Off the top of my head, I do not think that an antibiotic would affect it, nor do I think an infection would generally affect the diagnosis. Now, when you have an infection, whether it's bacterial or viral, your white blood cell may climb, your white blood cell levels may rise. And that's just the WBC number may go up. If you have a bacterial infection, we often will see the neutrophil count go up as well, and that's called a left shift. But if the WBC count goes up, that's a suggestion that there's an infection. That can happen in either bacterial or viral infections. If the neutrophils go up, that's a suggestion that it's bacterial. Sometimes lymphocytes or monocytes can go up if it's viral. But does it affect the diagnosis or the follow-up? Generally, the white blood cells would not play much of a role in the diagnosis or follow-up of Waldenström's in general.
Okay. So aside from the IgA and the IgG levels, what else might make you suggest to estimate immunosuppression?
Well, I think in the clinic, most of the time it's really the gestalt of the hematologist-oncologist. We would look at things like how much chemotherapy a patient has received, because the more chemotherapy you have, and especially if you're actively receiving chemotherapy, your immune system may be impaired. Your age, so older people are more susceptible to infections for a number of reasons. Your what we call performance status, which just means what kind of physical condition are you in? Are you able to walk 3 miles a day, or are you really sitting around the house 50% of the time, and the other 50% of the time you're in bed? Those things, I think, go a long way to estimating somebody's susceptibility to infection. People who are more physically vigorous, no matter what their age is, are less likely to get an infection. People who are actively on chemotherapy treatment are more likely to get an infection than those who are not. Exposures, for instance, if you, I think that we don't place that much concern regarding exposures. If you're certainly somebody who worked, was seeing the public all day long in a job where they're with the public, say they're working at a restaurant, is going to be higher risk than someone who's has a security job and doesn't interact with the public at all. That it has some impact on your chances of getting an infection.
So are the IgA and IgG affected by WM? Do you need to be concerned about the low IgA or low IgG levels?
In general, they're within normal limits. Now, the drugs that we give can lower them. IgA is generally not an issue in Waldenström's. IgG is a key a key immunoglobulin in fighting infections, very important immunoglobulin. And people are born with a lack of IgG, and they die from infections fairly early unless we can do something to fix that. Now, some of the drugs we use lower IgG. Rituximab, for instance, is well known to cause a condition called hypogammaglobulinemia, where a patient has very low IgG levels. So paying attention to your IgG is worthwhile. Now, the routine approach, and I think it's the right approach, is not to do something about the IgG level if you've been feeling well and if you haven't had recurrent bacterial infections. So if someone has a low IgG, let's say it's 300, but let's just say it's below normal, significantly below normal, so we don't get confused with the units. But it's significantly below normal. We will, in general, hematologists, oncologists will not replace it, will not give you IVIG or IgG to raise that level up to normal. Now, it can be done. There's a product that has many different names, but basically it's IgG that is collected from patient donors. So there are a number of products where it's concentrated IgG, and this can be administered to patients every few weeks to raise their IgG. It lasts for several weeks. You can get it every few weeks to keep your IgG closer to the normal range, and it can decrease the risk of infections, especially in people, as I mentioned, for instance, children who have no IgG and are at very, very high risk for fatal infections. It can definitely save their lives. What's unclear is when to give it in an adult who has low IgG levels, for instance, because of a disease or from chemotherapy, from something like rituximab, which I'm calling chemotherapy, but it's really not chemo. But rituximab can definitely lower IgG. So should we give you some IgG product to raise your IgG? The answer is usually not. Many years ago, IgG was routinely given to a very large number of people who had low IgG levels, and it turned out when it was studied that it generally did not improve life or decrease infections for the average patient. But in people who were having trouble with infections, it can make a difference. So my practice, and I think the practice around the world, is that if your IgG is low, don't treat it unless the patient is having problems with serious infections. Not little colds, but serious infections. IgG is hard to get. It's very expensive. It has its own set of side effects. And it's I think, an international shortage. Certainly in the United States, there's a big shortage of IgG. So, and there are lots of people whose IgG is low, but they feel fine. So if we gave it to everybody, the shortage would be terrible. It wouldn't be available for anyone. So short answer is, I don't replace IgG unless somebody has recurrent bacterial infections. And it is important. Go ahead.
Okay. There are a couple questions on viscosity. So if you have increased viscosity, can that affect a pacemaker? Or can diet affect viscosity?
Interesting questions. No, I don't. A pacemaker would not be affected by increased viscosity, and diet would not affect your viscosity either. Those are great questions, but the answer to both of them is it would not affect it.
That was quick and easy. So can you have free light chain only WM with heavy bone marrow infiltration, like is possible with multiple myeloma? Someone says, my IgM is normal, but kappa-free light chains were initially over 1,200 milligrams per liter before the first line treatment, and it's normal after treatment.
Well, I have not seen a patient like that, and there may be a report of patients like that somewhere. It's certainly very rare. virtually all, I'm not going to say 100%, but virtually all patients with Waldenstrom's will be secreting IgM in excess, the whole protein, the immunoglobulin, the antibody in excess. There may be extremely rare examples of people who don't. Now, we do know an interesting side point to that is, let's say your IgM is within the normal range. What I don't know when I'm looking at somebody who looks like they have Waldenstrom's or myeloma, but let's focus on Waldenstrom's, their IgM is in the normal range. I don't know if I'm just looking at the IgM whether all of it is normal IgM. So the only way you would know that is to get an electrophoresis, which in my talk I had said that's another number that can confuse you. But the one thing about an electrophoresis or a serum protein electrophoresis or an SPEP or an M-spike is that it separates the abnormal IgM from the normal IgM. So you could have the presence of where you're secreting an abnormal IgM protein, but still have the IgM within normal limits. But that would only be detected if you had a serum protein electrophoresis. So it's possible. I could see it being possible. Many WMers have elevated free light chains, many but not all. So that could be a clue to the diagnosis as well. But the vast majority have significantly elevated IgM levels.
That's something a lot of us look at.
Yeah, yes.
So how is amyloidosis diagnosed in WM patients? What are the early signs that patients should look for?
That's a wonderful question for me because I'm really interested in amyloidosis. And I have a number of WMers who have amyloid, but I do want to counsel you that it's unusual in WM, fortunately. But those free light chains we were talking about just now, if you'll remember, I don't have a diagram to show you, but if you look at a picture of the IgM protein, it's actually 4 different proteins that are attached to each other. It's actually 4 pieces. And two of them are called heavy chains and 2 of them are called light chains. In Waldenstrom's, many patients will secrete light chains that aren't attached to the heavy chains. And so these proteins are literally, the name actually gives it away. The light chains are the smaller proteins and the heavy chains are the bigger proteins. So these free light chains can circulate in the body, and in some patients with WM, most patients this is not true, the free light chains that they make are abnormal, and they're sick free light chains, they're abnormal free light chains, and when they're circulating through the body, they will go to certain organs and deposit in those organs, and over time they may pile up and create destruction of those organs, damage and destruction. So it's the free light chains in a small number of WM patients. Most of you with free light chains, this is not happening, but some people are making abnormal free light chains. They pile up, I'm giving you a long answer, in certain organs. Well, the organs they like to pile up in primarily are the heart and the kidney, often in the intestines or in the nervous system. So the most common symptoms and the symptoms we really worry about are cardiac symptoms, heart symptoms, shortness of breath, difficulty walking, trouble walking up a hill. You say you used to walk every other day with your spouse or your significant other a mile or 2 or 3 miles, and now you're finding you can't keep up with your significant other anymore, and you're not quite sure why. You're wondering if it's just getting old. You need to get your heart checked for a lot of reasons, including if you have WM, including you could have amyloid. So the free light chains pile up in the heart, damage, and they can destroy the heart, and so you develop a form of heart failure. And your ability, what happens when you have heart failure, your ability to do things diminishes slowly, steadily, month after month, year after year. Kidney failure is harder. You often won't have symptoms from kidney failure, but edema, swelling in your ankles, and foamy urine are common signs of amyloid in the kidney. So foamy urine, the foam is the proteins that the kidney is losing, is spilling because of the damage from the amyloid. Those are two of those are the most common organs to be affected, and those would be some of the more common symptoms. Weight loss. We always talk about patients having an enlarged tongue in amyloid, but that's actually not that common. Only about 15% of people with amyloid have an enlarged tongue. But if you start developing an enlarged tongue, it should be checked. And the other thing is spontaneous bruising around the eyes. So it may look as though you got punched in the eye, you got in a fight, but you didn't, and those things come and go. That can be a sign of amyloid as well. But the thing to worry about the very, very most is the heart symptoms, because that's what can really injure somebody with amyloid. It can really shorten their life if you get amyloid. So if you're feeling like, gee, I wonder if I'm just getting old, maybe I am, maybe I'm not, I can't do what I used to do, see your primary care physician, consider seeing a cardiologist, making sure that your shortness of breath or problems walking up hills or walking distances are not due to heart failure, or that might be due to amyloid.
Okay, our last question is fairly general, but a really important one for everyone who depends on what's in the pipeline for upcoming treatments. So the question is, explain how a clinical trial works.
Okay, thank you, Shirley. Well, this is always, I find exciting to talk about because it's what I live for, and that is for me to be part of clinical trials that are going on in the United States and around the world, and to contribute in my small way to improving the health and welfare of patients with these diseases. So it's really interesting to me. I think 10 years ago when I got here to Seattle, doing a research trial in Waldenstrom's was considered to be maybe not impossible, but extremely difficult. How in the world can you study a really rare disease? It's going to be very hard to make it happen, and maybe it just isn't going to happen. But because of the internet, and of course we didn't have Zoom back then, but with the internet and the support of the government and pharmaceutical companies, we are now able to do research studies in rare diseases like Waldenstrom's. So the nature of these diseases in general right now, the new drugs are produced by pharmaceutical companies. They are sometimes produced by universities, scientists at universities who may synthesize a new drug that will work for a disease. They're often, though, produced or created by a pharmaceutical company. And then the question is, once you have a drug that you think may benefit somebody with a certain disease, you have to show that it first of all, that it's safe. The critical thing, the number one thing we do is it's got to be safe. And if it's safe, then does it help patients with the disease? So studies right now are phase 1, 2, and 3 around the world. Phase 1 trials are generally small numbers of patients, maybe 30 patients. And we give the patients a drug that's never been, for instance, a drug that may or may not have ever been given to human beings before. And we see how the patient responds. What are the side effects from the drug? Is it really, really toxic, meaning you're not going to be able to move ahead with the drug? Or is it reasonably well tolerated? And if you're lucky, in those 30 patients, the side effects were low. And a few of them, a handful of them, their disease got better. If that happens, that will really encourage the scientist or the university or the pharmaceutical company to move ahead to a phase 2 trial. Phase 2 are bigger numbers of patients, maybe 50 to 100 or 30 to 100 patients. In the phase 2 portion, you know the drug appears to be safe, and you think you've found a good dose, and you treat a bigger number of patients with the idea, with the hope of getting a better handle on how well patients will respond. And often in 2020 and going on into 2021, we are now combining phase 1 and 2 trials together. So if the phase 1 is successful, you move right into the phase 2. In the past, they would be separate studies, and there could be big delays between opening a phase 2 from a successful phase 1. To avoid that, they're now combined phase 1-2 trials. That's the way many trials, if not almost all, are these days. So if phase 1 looked good, the drug appeared to be safe, and a few people responded. In phase 2, you're continuing to see good signals, the patients are responding, and it's not unsafe, then you move to the phase 3, which is the ultimate trial that gets, usually a phase 3, that gets a patient, gets a drug approved. And those will be generally studies with, in most diseases, hundreds of patients. Now, I believe it was the study that got ibrutinib approved for Waldenstrom's, I believe, was a phase 2, and it wasn't randomized. And that's because Waldenstrom's is an unusual disease and very difficult to get new drugs, and it was thought to be a disease in need of a treatment. So the FDA did approve it. So then back to what do you do? Where do patients come in? Patients, they're critical to all of this. Nothing happens unless patients, falling down on the job. Nothing happens unless patients volunteer to be part of these trials. So when you volunteer to take part in a trial of a new drug, for instance, there may be a trial using venetoclax in Waldenstrom's in the near future. There may be an international trial. There may be other international trials. We just finished one using the next generation tyrosine kinase, zanubrutinib, in Waldenstrom's. When a patient volunteers to be part of that study, you are making a difference. We are learning from that study, from these studies, and hopefully we're going to develop a new drug. If we don't develop a new drug, hopefully we're going to learn things that'll help us in the next study to develop a new drug. So I recently went up to a patient of mine who was involved in one of my studies, in one of the studies I was involved in. It's an international trial, and the drug was just recently approved, and she participated in the study, and I thanked her for being in the study. I said, I just can't thank you enough. You made a difference. That drug is approved. She's actually in a remission. This was in a myeloma study. She's actually in a remission, but it's due to her efforts as much as anybody's that this drug is approved. Without you volunteering, these drugs will just be, all we'll ever have is what we have today. We will not have new drugs. So they have to be studied. Fortunately, we have these studies to prove that these drugs are safe and effective. So that why do we go through all this hassle of a study? To prove that they're safe and to prove that they're effective. So it's for your benefit. I totally understand if a patient's not comfortable being in a study. That makes perfect sense to me. But if you think you can find a way to participating when they're available, love that too. That is absolutely fantastic, and that's what gets me up every day, is to do these trials, and of course to speak with you.
Well, thank you very much. We really appreciate all your time and expertise dealing with us and explaining things that we deal with all the time, our blood work. And thank you to everyone for joining us. We're really appreciative that we have this opportunity for further education. Thanks again.
Thank you.